there's this like middle zone of helpfulness where one end, there's clearly a boundary violation and the other end is maybe a boundary crossing. And there's no bright line, right? When you're taking care of a family member or a friend, it's not like an alarm is going to go off when you cross a boundary and make a slip. So thinking about it in advance is really important. And talking with your colleagues openly.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. And today we're talking with Lucia Wocial, Senior Clinical Ethicist at the Lynch Center for Ethics at the MedStar Washington Hospital Center in Washington, D.C., about ethical considerations for when people you know become the patient. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Lucia.
Thanks very much for inviting me. I'm really excited to be part of your podcast.
Well, before we jump into the direct topic, I think let's start to briefly elaborate and help define the concept of nursing ethics and how nurses might encounter this concept in their routine practice.
So people often ask, is nursing ethics a specific class of ethics? Is it freestanding? And, that's a philosophical debate, which I think is less relevant for nurses in clinical practice. What I think about is nursing as a profession is relationship-based, and it really focuses on, when you think about nurses, how they interact with patients, how they interact with their colleagues. And the other piece that defines nursing ethics is, what does it mean to be a good nurse? So nursing as a profession is very much linked to what we call virtues, what it means to have good, strong character traits. And so nursing ethics is about doing the right thing in relationship with others. I guess it's a short way of saying it.
Thank you. Thank you for providing that grounding definition as we move forward. So how does that concept relate to the ethical considerations that we as nurses will experience when we're caring for people that we might know on a more personal level before they became a patient with a cancer diagnosis?
Yeah, that's why I thought it was really important to start out by saying nursing ethics is relationship-centered, because when your friend, family member, colleague becomes a patient, that relationship can't be uninformed by how you know that person before they got sick. And so the first thing is to recognize you know them. You can't not know them. And caring for them poses some fairly unique challenges in terms of, how do I maintain professional boundaries? People talk a lot about nurses as the most trusted profession. And I think one reason people believe that is because we're caring for people when they're at their most vulnerable. And if you are taking care of a colleague in a professional capacity, you have access to their medical record. That's private health information. There's a lot of information that you have access to that your colleague or your friend or your family member maybe would hope that you didn't have. And it may be important information for you to take care of the patient, but it really, really stresses how it's important to maintain your integrity, the integrity of what it means to be that nurse. And can you separate your role as a nurse from the role you had with them before they got sick? This comes up a lot, for example, in small towns. If we're the cancer center for the, 300 miles, and I'm the cancer nurse and one of my family members gets cancer, chances are I'm going to be their nurse. And if I work in the best cancer center, I want my family to come there. That it can just be really hard. And I think what people don't really think about is there's this power differential. Patients are vulnerable, and we know that, but people forget that we're vulnerable. I have to maintain this different role. I have to take care of myself. I may have access to information that may be quite upsetting, and I still get to be professional in my job. So, for example, let's say my best friend is diagnosed with cancer and she and I socialize on a regular basis and I'm taking care of her. And she says to me, do not tell my husband X, Y, or Z. And her husband, who happens to be a friend, says, how's she doing? And, has she talked about blah, blah, blah? And you're like, well, the truthful answer is yes. But she's asked me not to talk about that. And I'm probably not going to say that. So that's a situation where you have to ask yourself, is it okay to lie? Is it okay? And is just not answering the question lying? Is it a lie by omission? That's a really concrete example of one of the many challenges that may come up.
Absolutely. I think you brought up more than a couple of great points there. One that really stuck out for me is, you mentioned if you are in a small center or, you're the only cancer center within any distance. So you can't do what I think is common in maybe larger centers, whereas you do try to create maybe that distance where maybe you're not the one directly administering their treatment or directly, working with that physician who's caring for that patient, trying to create some of those intentional boundaries, environmentally speaking. I mean, those things are sometimes possible when you're working with a large staff at a large center, but that's not always possible.
Even when it's possible, it's hard because all of your colleagues know that they're taking care of your sister, right? So they're like, oh my God, like, what's she going to say about, it's awkward. It's just awkward. I'm an ethicist, so I think of that as an ethics challenge. Other people maybe wouldn't name it as an ethics challenge, but for me, I do, because it's largely because of the access to that information that you have.
And I think the other thing you mentioned that I thought of as you are speaking is just sometimes it's not even the direct care. It's, when your friend, maybe they live across the country, but their spouse gets diagnosed with cancer and they know you're a nurse that works with cancer. And so you might not be involved directly in care, but you are tapped by family and friends for your knowledge, for your expertise. And I think the same ethical dilemmas will present themselves when, they ask, how bad is it? What are their odds of survival? And one, those aren't questions we can really answer with certainty anyways. But then again, those same scenarios you described of like, I don't know that I want to answer this or be the one to have to give that news. It's not always direct care, but even just being in relationships with people who are going through a cancer diagnosis and they know that you might have information that can help them. And so that scenario, even for nurses, maybe they're not in direct patient care anymore. They're doing other roles, but I think we all can identify with those scenarios that have come up in our lives and how that makes us feel a little uneasy.
Would it be okay if I gave an example?
Absolutely.
So I know someone who is a nurse and her sister was diagnosed with lymphoma. And she flew out to take care of her sister and was talking with her husband. And of course, she knew the statistics, right, of survival. And just in having a conversation, she just said something about, 50-50 chance after 5 years. And just because, she knew that. And then suddenly she looked at their faces and like that was the first time they'd heard it. And so, to have to think that hard about what am I going to say? And she wasn't trying to spill the beans. She wasn't trying to, she just was just part of her knowledge base. And so, wow.
Well, exactly. It's like what you're comfortable in the way that you're comfortable talking about cancer in your professional setting with your professional colleagues. There are things and inferences and just there's a different way that we talk amongst our peers in that clinical setting versus when we're talking directly with a patient. And when you're with someone who you're already comfortable with because you have that relationship with them, sometimes it's hard to keep those boundaries in the right place, which is kind of where we're going to go next in our conversation is when you are caring for somebody that as more than just a patient or is somebody, a friend or a colleague or a family or friend of a colleague. So again, there's a bunch of triangulations of how these scenarios can show up. It can be a very personal experience. And we know that setting up those boundaries are critically important in kind of maintaining those different types of relationships. What challenges can arise when trying to sort of initially establish those boundaries?
So my clinical background's neonatal intensive care. So we see our patients for long periods of time, as do oncology nurses. Many oncology nurses will see patients over years. So they develop relationships with them. It is hard. And then again, maybe you see those patients outside of the hospital. And it's hard to turn on and off the professional you from the personal you when those natural relationships form. So how can you prepare yourself for that? It's not really rocket science. One is, honestly, think about it. Just think about it. if you are in an environment, if you're in a small town, if you are at an important cancer center, even in a mid to large city, if you're like the cancer center, people are going to come and want to be cared for. So chances are pretty good that you will one day encounter someone that you know in this professional capacity. And so, thinking about it, I will say one helpful resource, the National Council for State Boards of Nursing. It's a document really that looks at, how to maintain your boundaries. They've actually enhanced what is available in terms of they have videos on their website and they have a brochure that sort of helps you think about it in one way. I will say it's challenging in another way because it says there's this like middle zone of helpfulness where one end there's clearly a boundary violation and the other end is maybe a boundary crossing. And there's no bright line, right? When you're taking care of a family member or a friend, it's not like an alarm is going to go off when you cross a boundary and make a slip. So thinking about it in advance is really important. And talking with your colleagues openly about, hey, we have, let's say, and this does happen, all the nurses on the oncology unit, and one of the nurses on the oncology unit gets cancer. So having an open, transparent conversation about how are we going to do this? How are we going to protect this individual? How are we going to maintain our boundaries? How are we going to not get emotionally involved to the extent that it clouds our judgment as a nurse? That's the biggest danger, right, in this boundary crossing is that I will say that one of the things that nurses frequently do to convince a patient or a family that they care is they'll do something special for them. And sometimes the something special is they'll get them coffee the way they like it made. Not a big deal. Go down the hall to the nutrition room, get the coffee. Not a big deal. Sometimes, and I know this is a lovely story from a place where I used to work, the patient's husband commented that his wife always had her nails done. And one of the things that was really hard for him is, her nails weren't done. She'd been in the hospital a long time. So the patient's primary nurse gave her a manicure. And for him, for the husband, like that was a big deal. The patient wasn't able to interact and she was clearly nearing her death. But that one tiny little thing was a big deal. So is buying a bottle of nail polish a big? No, probably not. Right. And that time that you spend, but that's creep of boundaries, right? Let's say you have a patient or a family friend and you know that the family is struggling financially. Should you all arrange a food train? Maybe, maybe not. Would you do it for every patient? Is it like, this is really how I think about it. It's boundary creep and just talking about it and thinking about it every step. And if your colleagues say to you, hey, I think you're a little bit overly involved with what's happening. Maybe you should take a step back. Listen, as hard as it is, listen. I know I had a friend who delivered a baby prematurely and I was working for an agency. They asked me if I would pick up an extra shift and I said, sure, I will do it as long as I can take care of her baby. That was a mistake. First of all, they let me do it, which was stupid. I'm a competent nurse, but that was right. Somebody needs to protect us from ourselves. It wasn't that I thought I was better than anybody else. Like I wanted to support her by being the one because she knew me, she could trust me, right? And so some people talk about it as Messiah complex, right? If you think you're the only one, then little bells should be going off in your head.
Well, and I think you made some great points of just if there is a unit of nurses working together and there is a patient now that they are all familiar with, if it was a colleague or what have you, just having that open and honest conversation, establishing and normalizing, like we have to talk about what this is and how this is going to impact us and what can we do as a group and on individual levels, like what can we do to make sure we're protecting ourselves psychologically, emotionally, and as you mentioned, mentally, we have to stay grounded in what our purpose is as a nurse and the knowledge that we have to use to make those critical decisions. It's all something that I think is hard to talk about. And a very, very important step is to have that conversation openly and just talk about how uncomfortable it's going to feel until those boundaries are established and people get more accustomed to what that patient's care might look like because there is that relationship.
You mentioned something that I think is really important, and you can't have a conversation these days without referring to the pandemic. So I apologize. I know people are tired of hearing about it. However, one of the things that we learned in the pandemic, we sort of knew it before, and that is So in the Code of Ethics for Nurses, people often forget that one of the provisions is actually we owe the same duty to ourselves that we owe to our patients. And we're terrible at this. We are terrible at self-care. Absolutely terrible. That's one of the reasons that the boundaries are so important. You have to take care of yourself. You have to be able to separate. You have to be able to say, please take good care of my sister and don't let me get in your way. Please do that. And I need to keep that a clear boundary. I have to go home and I have to eat a meal and I have to be able to go to my colleagues and say, I just learned something terrible. Can I talk with you about it? Will you be my secret keeper? I can't talk to anybody else about this and I have to share it. And it's sort of that unburdening yourself with that information. That's really important.
And as you said also before, of if I am demonstrating behaviors that you as my peer recognize are creeping or kind of headed down a path that maybe isn't going to end well or be healthy for me, I want you to call me out on it in a gentle way, in a kind and empathetic way.
Unless I need it, please don't beat me over the head about it, right?
You don't have to yell at me from across the nurse's station. But yes, I mean, it takes that sort of like, help me help myself.
Mm-hmm. Yes.
Because in these situations, sometimes even the best of us can't. We can't always help ourselves when we are emotionally wrapped up in something that is very important and very distressing. Sometimes it takes us to reach out to our colleagues and say, I need you to help me, or I need you to don't let me get in your way and help me not get in my own way. It does take that trust and that vulnerability to turn to your peers and say, I'm going to struggle with this. Can you be my person? Can you help me? And so those are really important things to talk through when these scenarios come about.
I'm going to post something that's slightly different that's hard to think about, if that's okay.
Sure.
So we've been talking about boundaries where there are people who we have close relationships, we have deep caring feelings about, and, it's hard to separate because we're feeling the pain of their illness. There are situations where we find ourselves in a position where we need to take care of a colleague who, frankly, is not a great colleague. Maybe isn't the most helpful person when you work on shift, or who, that's hard to talk about. How do I extend them compassion? How do I be just as good a nurse and be just as compassionate and think about, would I do a manicure for her because it mattered to her husband, even though on any given shift, she makes my life miserable. And I think those are sometimes harder. Although here's what I have learned about nurses. When patients are facing end-of-life situations, the compassion that oozes out of nurses it's like a flood. And I have seen people rise above. So, for example, nurses taking care of patients who are frankly mean and get angry and throw their bedpans and complain about everything and on and on and on. And then the patient gets a terminal diagnosis and there's no more treatment options. And suddenly nurses are like, well, wait a minute. What do you mean they're going to die? And then suddenly they're able to rise up. I mean, it is just stunning. It's one of the things I think for me that makes me proud to be a nurse when I see people do that.
Absolutely. And I think, again, bringing it always back to COVID, I think we, despite all of the feelings and emotions that nurses felt throughout and continue to feel in some ways of being valued and heralded a hero, and then suddenly it felt like that was not the true at all. And despite all that, still showing up, still doing what needs to happen. And again, I think we're already building the beginnings of another podcast. But you think through all of these all relate because it comes down to that ethically, what is our role as a nurse? And then when you can place that question into any context and tease out, what are these sort of dilemmas and ethical little conundrums that we'll have to work our way through. And that's just everyday nursing because you can't avoid those. They will show up every day and in every way. And so, as we've talked about already, a little bit of just taking those steps to understand what the boundaries need to be and identifying your peers or your own practices that could help to not only establish them, but keep them balanced. I think those are really important skills that are beyond even the scope of what we're talking about today.
I love the fact that you mentioned that hero thing. It sounded good and it felt really great. And like, wait a minute, I'm not a hero. This is my job. And by the way, I'm really tired and I don't think I can be a good nurse today. I can barely keep my eyes open and my feet are dragging. And I know for a lot of people, the caring for family and friends, this setting high expectations for yourself, that you will be able to make sure that their care is exquisite and quote unquote perfect, even if you're not going to be the one there. And how do you maintain that? that's a recipe for something that I spend a lot of time thinking about, and that's moral distress, thinking that I know the right thing to do here, and there's something that's keeping me from doing it. Maybe the thing that's keeping me from doing it is physical exhaustion. Maybe the thing that's keeping me from doing it is I know something about this person personally, and I don't know if I'm able to share that because it's going to have a big impact on how their treatment course goes. Or the physician was talking at the desk about prognosis and everything else, and I learned something, but the physician turns to me and say, I don't want you to talk about it. Well, wait a minute.
Right.
Wait a minute. And whether that's a personal friend or a colleague, it's harder when it's a personal friend or a colleague. But in a professional world, it's not inappropriate for the oncologist to be the one to disclose the diagnosis. And timing is important. And it's not infrequent that oncology nurses know test results before patients do.
Absolutely.
That happens a lot. And of course, your colleague's going to say, I know you know. Right. I know you know. Like, I work here. I know you know.
Just take a little peek, just take a little peek and just let me know what it says.
Tell me. And so how do you say with compassion, you're asking me to do something that you and I both know I'm not supposed to do. And I wish I could help you in this. And if you trust your doctor, we owe it to your doctor to be the one to share with you what the news is, which even if you say that your colleague is going to know, right?
That's bad. It's bad, right?
Bad news. Here's the deal. There's nothing you can say that's going to make it better. There's nothing you can say that your colleague or your friend won't read into it. And, if you have a smile on your face, and of course, we're talking about the gloom and doom, right? It's a terminal diagnosis. Well, sometimes the diagnosis is, yay, we have, chemo that's going to work. This is,
not this, or, this is the marker we wanted to see. So this is good. Yeah, you're right.
Right. So it's not always bad news. I tell people all the time, ethics is not always death and dying. That's just the hardest thing that people do.
Right.
But, sometimes you have good news and you don't get to share that either. You just have to wait. So what if the ethical challenges that come up as oncology nurses, you all have experience with the physician colleagues that you have? Some are more skilled than others about delivering serious news. And so, you may have, and I worked with a physician, brilliant. The man could speak genetics, microbiology, like talking about a card game. And his bedside manner was stilted and stiff, and he cared deeply. He just didn't have really good people skills. When you think about not just, oh my God, is he going to be the one to give the news? What can I do to soften that blow? So here's what I would say. Why wait until it's a family member or a friend that physician has to talk to? Why not reach out sooner and say, hey, Dr. Bob, and I always call them Dr. Bob because it's just, I need somebody. Dr. Bob, can I talk with you? I see that you care deeply about all of your patients. And I wonder, can I be with you? Can I help you when you have these conversations? Because it seems like they're really hard conversations and I want to support you. And I think we forget about that. That's the relationship of nursing ethics, right? I have relationships with my patients, but I also have relationships with my colleagues and physician peers. So thinking about how do I care for them when they have to deliver news? Because they know, let's say they know the person too, somebody they work with. It's about building relationships, really. That's what I think about more than anything else.
That's wonderful advice. And you're absolutely right. I think we all know and have experienced that part of our practice where maybe we've heard in a conversation, whether it was maybe a fellow or a new resident, and you're not that they should be ones giving those types of conversations, but even if it
happens,
well, yes, it does happen. And yeah, it's not easy. And you feel for those physician colleagues because that's a skill, that's training. And maybe they either haven't received training, it's not going to be in their skill set just based on their personality type or just their way they communicate. And so, how can we as nurses help step in and be part of that? One situation I frequently, because I worked with a surgical group, part of my practice as our physicians were tied up in the OR 3 to 4 days a week. And so when a patient is waiting for results or waiting for information or waiting for a callback, and I know the answer. I have the information. I have the results. I have what is needed, but am I the right person to take the next step and talk to that patient or give them the information? And, when's the right time to do that versus not? I don't know that there's always a black and white answer for patients that I knew for a long time. And this was just a sort of, maybe it was a biomarker that came back and showed, unfortunately, it's going up, not down. I mean, those types of conversations sometimes I did have, because I'm like, this patient should not have to wait 4 days. And I think another layer of complexity, now that patients can see their information in their online portals relatively immediately, we can't wait. We can't always wait for them to be back in the office. Certainly, some of those conversations need to be face-to-face to provide the type of support that's really required. But patients aren't going to wait a week to come back and see you. They're going to call you and say, what does this mean? Or what do we do now? Or what's the plan? And that was always the piece that I couldn't always answer, right? I don't know what the next plan is if we're on the third or fourth line. And so I can provide the information, I can provide comfort, but I can't give you what you really want to know is, what do we do now? And living through those types of kind of morally distressing scenarios, it can be challenging. And that can be, even with a family member, they're like, hey, I got my scan. Will you look at my results in my portal? And what do you think? I don't want to look at them.
I think that boundary piece, when you're feeling pressed to answer a question that you know the answer to, sometimes a really effective strategy is, I'm not sure about the results. Can you tell me what you're worried about? Can we talk about that? And it's a form of deflection. There's no question about it. I think, one of my many crusades is that nurses are so well positioned to have conversations with patients about values and goals, not about treatment choices. That's what doctors have to do. But if you can learn about patients' values and goals, you can help them and you can help doctors frame serious news that they have to deliver. And so we're the most trusted profession. People look to us. People think that they can have these conversations with us. And, especially oncology nurses, for heaven's sakes, like ICU nurses, you're about 2 weeks ahead of everybody else seeing where this path is going to go. And I have had oncology nurses talk to me about, patients who show up in clinic for chemo and they're going to go down. And they're still full code. Nobody's had this conversation. They don't know that, they're not going to survive. And so, whether it's a colleague or a friend, that makes it worse. If it's somebody, and see, I think about this for oncology nurses. Some of these patients they feel like your friends because you've cared for them for years. So maybe they're not your friend from high school, but you have a deep relationship with them that's been built over several years. Those are the times where you feel like somebody's got to have this conversation. Somebody's got to do this. And I know the information, like, what's my role here? What is the code? What does the code of ethics tell me I'm supposed to do? It's not about a clear boundary or given the test result. It's about how do you build that relationship and how do you engage them in a conversation about what are they worried about? What do they think is happening? Are they willing to talk about, the hard things, which is honestly, what if things don't go the way you hope? Can we just talk about it? And that's a boundary that I think everybody should cross.
I love that. I think that's so important. And just that's a great little phrase to keep tucked in your pocket as a nurse when you encounter those situations. You'll have that patient, oh, well, my last treatment failed, but don't worry. Doctor says we've got a fifth line and we can try. We know what that means. And maybe deep down that patient knows too, but maybe not. I love just that question of like, there's always hope. Is it hope for cure? No, you can't always have that hope, but there can be hope for ensuring the patient is involved in decision-making, has clear understanding of where their disease is likely headed. We can have hope that they are able to identify their goals of care and make sure that their end of life meets what they're hoping it will be. And we can only do that. We can only keep that hope alive if we have those conversations early at the right time when we can tell that the road is going to lead there at some point.
Yeah, I think nurses really struggle with, and I know people have asked me this all the time. So what if they ask me, what would you do? What would you do? Do I answer the question? So when people ask me that question, I learned fairly recently a really nice way to answer that question. First of all, I'm not you, but I'd like to help you think about it. Can I help you think about this? I do too. I wish I could remember who I learned it from. I had it on a Post-it on my wall at one point. And sometimes patients will, even after all of that, they'll still press, well, what would you do? And as long as you're clear and say, I'm not you. If I tell you the decision that I would make, I need to tell you why. And here's the decision I would make, and here's why. So you mentioned something when you were talking, and it made me think that nurses, I think, really struggle with Dr. Bob again. Poor Dr. Bob. Dr. Bob is like a dog with a bone. He will always find a new, line of chemo, and he's clearly uncomfortable with death. And these patients, it's just unfair. Nobody ever talks to them about it. Why doesn't somebody just tell them? This is a boundary issue. Dr. Bob is a fabulous physician, but he just cannot get this thing. And so what could you do, right? What's within your scope of practice? So it is within everybody's scope to ask permission to the patient and say, would it be okay if I shared something with you? And what you want to share is, I'm worried. Would it be okay if I shared what I'm worried about? If the patient says, sure, then, say, I worry that maybe things aren't going the way that we would have hoped. And I worry that we haven't talked about it. Or I worry that, honestly, what oncology nurses have described to me, what they've seen in the ambulatory care clinic, I know you all have moral stress. I know you do, right? Patient comes in and you do their vital signs and their BP's like 80 over 50, and they're looking, you can't find a vein because they're dehydrated. Like, okay, this is bad. This is bad. And they're still listed as a full code, and there's no evidence in the record that anybody's had any conversation about it. And there's no way I'm going to run chemo today. And, what ethically am I supposed to do about this? And for me, the ethical thing to do is to invite the patient and their family, if they're there, to talk about it. I'm worried. Are you worried? Can we talk? What are you worried about? And honestly, in the United States, people still think that death is optional, as far as I can tell. Nobody talks about it. Even nurses, you ask, how many of you have an advance directive? How many of you have talked with your friends and family, put it in writing? And still, I don't see 100% of the hands go up, which is crazy. Sorry, I can ramble on about a lot of this stuff. We think we've gone off.
I don't even care. This has been a great conversation. I think whether we're talking about just any ethically challenging situation with moral dilemma kind of wrapped up in everyday work that we do as oncology nurses, let's talk a little bit about what are the personal actions that we as oncology nurses can take to help address some of these concerns we're having. What's like an action plan that would help set our nurses up to be successful?
First action plan for me would be, if you haven't had the opportunity to practice the skills of having these conversations around serious illness, get some training. And you can read about it, but nothing will ever replace talking about it, like actually practicing those skills. So there are different programs that are available. There's something called Vital Talk, which is typically for providers. There's something called Impact ICU. There's some great videos on their webpage. It's interesting. Impact ICU initially started out for ICU nurses, right, who patients are circling the drain and nobody's ever had this conversation. So they have to come up to speed really quickly to have conversations with families. Oncology nurses are a little bit different. And what the Impact folk learn is that Impact ICU, actually those particular skills can also be used with oncology patients. So instead of Impact ICU, it's just Impact. How do we have this conversation? How do I practice managing those really intense emotions, which frankly nobody feels comfortable around unless you've practiced it, because people are going to cry, people are going to be angry. And how do I navigate those emotions? And then how do I help them focus on what matters most to them? And that takes practice. So an action plan is really practice this, practice it so you're comfortable with it. I believe that nurses are well positioned to do it. And in a practice like oncology, where a significant percentage of your patients die, this is one way to make that better, right? If you can't fix it, how can you make it better? You can make it better by making it possible for people to talk about the unthinkable. So that would be, for me, number one, get some skill training. Number two, take care of yourself. Cannot emphasize that enough. There are many practices that I really appreciate when patients die, creating a ceremony of, and it doesn't have to be elaborate. Even it's published in literature. It's talked about as a pause, even just taking 1 or 2 minutes to acknowledge before you have to, move the body to the morgue and turn the room around and admit the next patient. That's what took a huge toll in the pandemic. And what oncology nurses are experiencing now is all those people who didn't get their oncology care because of the pandemic are now coming in sicker and they're dying faster. There's a lot of death. Taking care of yourself is really, really important.
And I think, whether we are caring for and experiencing the death of a loved one who had a cancer diagnosis, or it's just any other patient, I think all of these skills are necessary and required for oncology nurses to learn. And it's not something that we will learn in school, at least those of us already in practice. We're not getting a lot of teaching on these types of skills. And even if we did, it might not be the right timing in our practice to really retain them, right? You're learning so many things as a new nurse. Like, this is maybe not for that year 4 of your baccalaureate program. But it is something that I think as nurses in practice that find themselves in practice settings, where this is a skill set that's needed. As you mentioned, like this is a place where continuing education focused in this type of communication and delivery is so important. And not that nurses have all the time in the world. We're not playing card games, whatever that whole issue was a few years back. We know that's not our life. We are busy too, just like physicians are. But we hopefully are afforded more time to sit with patients and have these types of conversations, even early, even just asking, like, have you thought about your goals of care? It doesn't have to be when we know that they're a few months maybe out from dying, but we hopefully have more time. And I think patients also, because they trust us, are more open and willing to entertain these types of conversations with us as nurses because of that different relationship that we have with them. And so I think this is certainly an area where practicing oncology nurses, if they don't have this experience or this comfort or training in this area, it's certainly a place that we need to investigate and dig a little deeper because it does make us better nurses in caring for our patients.
These conversations don't have to be long in order to be powerful and impactful. They don't. That's part of the communication skills training. You can learn a lot, some really important information in a very short amount of time. And learning that information in terms of patients' values and goals can help transform treatment recommendations if they can be placed in the context of a patient's values. So it doesn't have to take long, but that does take practice.
And it doesn't have to happen all in one conversation either. Have a short one. Start it out, ask the question, get them thinking about it. Maybe they don't have an answer or they're not really ready to answer. Maybe when you bring it up when you see them in 3 weeks' time.
Can I make a silly suggestion? Listening to you talk about this, and as you say, if I'm an ambulatory oncology nurse, I know I'm going to see these patients over an 8-week chemo period. We say to the patients, so there are actually, you mentioned card games. This is what made me think of it. So there's one game that's called 5 Wishes, and go wish. And you can say to your patients, you're going to be coming for 8 visits. How about we play the game over these visits? It doesn't take a long time. There's another game called Hello, which walks you through about 32 different questions. The science behind the game is actually quite good. It takes patients between really deep and meaningful questions and then some light, more humorous questions. And so it creates this sense of psychological safety. I mean, if you made part of your 8-week chemo plan that every visit we're going to have a conversation about values and goals, imagine how that would transform practice.
Man, I love that.
I mean, think about it. You have it's like dialysis nurses. You're going to see this patient 3 times a week. There are things you can do to talk about this. And it's not like you don't have to beat them up. If they don't want to do it, they don't do it. But you might be really surprised. I might say, hey, can I bring my uncle next time? Can I bring my dad? Can you help me talk with my husband about this?
And then again, learning those techniques. And then if you are faced with caring for your friend, your colleague, your family member, how do we use all of these skills that are needed in our general practice and care anyways, and apply them directly when we're working with people who we care deeply about in a very different and unique way based on our relationship? I think all of these lessons are applicable in so many different scenarios that I hope and I know that our listeners will have learned a lot of interesting techniques and things to consider as they move forward in their practice.
Yeah, you said it earlier. If I'm transparent, if I say, this is back to the boundary issue, why you originally wanted to talk to me. So if you're transparent with your friend, colleague who happens to be your patient, and just say, for example, today you're my patient and I'm your nurse. And while I know more about you, that's between you and me. And I want to reassure you, I'm not going to share that with anybody else. And these are the boundaries that I'm setting for when I'm taking care of you. And, that will help you. That will help them.
Absolutely.
So be transparent and protect yourself.
Wonderful. Well, Lucia, we may have gotten 100 so miles off course, but I loved our conversation and we can keep bringing it back to family and friends and colleagues and it all applies. And so I don't need any apologies. I love what we talked about, but we are coming towards the end of our episode today. So to wrap things up, we like to usually ask a few kind of quick fire questions just to help summarize things. So to start that off, what are some common misconceptions about caring for someone you know as more than just a patient?
So common misconception is that it'll be easy because it's not. If you maintain boundaries, it's not. Common misconception is that you won't be put in awkward positions. If it's a family member or a friend, people, like you say early on in the episode, you said, here's my scan results. Can you just look at it and tell me what you think? No, I'm not going to do that. So I think the misconception is I don't need to think about it. if we're the most trusted profession and somebody in your family knows that you're the nurse, you're going to get called sooner or later. So think about it. Misconceptions, you will never have to encounter it. I don't work in a small town. It's not my problem. It is. It'll happen.
Absolutely. What's something about this topic that's not often discussed, but you wish people knew more about?
That's the self-care piece. People think about this in terms of patients are vulnerable and all the rest of that. And frankly, you're vulnerable. People don't think of it the other way around. So the boundaries are there to help protect you, not just the patient. And I don't think people realize that because they think it's all about the patient, but they're there to protect you.
And I think what we've learned, again, on the heels of COVID, is that we have to care about ourselves. Nobody else will, but if nobody else does, it's still left to us. And
we're bad at it.
And we're bad at it. So to preserve our ability to keep doing what we love, it falls to us to also ensure that we spend some time thinking about what helps keep us engaged in this profession. What can we do to ensure we do protect ourselves and give ourselves that time and space to heal or to be focused on our own needs, what will keep us engaged, present for ourselves, for our families, in the profession. Next question, what additional training or education do oncology nurses need to understand or prepare for ethically challenging instances, such as caring for someone they know personally?
So the NCSBN information on boundaries, the additional communication training, you can find that on vitaltalk.org. Those are the two things that I think would be the most effective.
Wonderful. And we'll be sure to link those, of course, in the episode notes for our listeners to access and learn more about. And then our final question, which we may have addressed, but we'll just revisit briefly. What are some additional resources for patients, providers, clinicians who want to learn more?
Learn more about boundaries?
Sure. Yes.
I think it's the same resources. So ONS, I'm sure, has resources that can help people. I will say the best thing that I know is that NCSBN resource that just helps people think about it.
And as you mentioned, ONS does have a great learning library for wellness, lots of very diverse activities available in there for nurses. And some are as simple as a 5-minute, some are a longer, kind of more involved thing. But we have done a great deal of work on trying to curate some of those resources and activities for nurses just to help them as we navigate through this interesting time in nursing.
I think there's one other thing that I need to mention. It's sort of a promise that I made to myself. So since actually 2017, the National Academy of Medicine has had an initiative on clinician wellness long before the pandemic hit. Since the pandemic, they've actually released an action plan for clinician wellness. And one of the things that I want all of your listeners to know about is the phone number 988. Do you know what that is?
No, I don't.
That is the National Crisis Hotline and Suicide Prevention Line. And the reason we all need to know about it is there's an epidemic of nurse-physician suicide in the United States. So if you have a colleague who you think is struggling, whether it's because they're caring for a family member or a friend, or they're feeling like they couldn't be the best nurse they could be today, reach out. Don't be afraid to ask. I say this because I'm honoring a colleague who I identified as having a high level of moral distress, and I reached out, and she died by suicide. So don't let that be your story.
And just keep that in mind as we are caring for each other, as we are caring for ourselves and looking after our colleagues in the ways that we can to support our teammates. Those types of resources are invaluable. And asking if they're okay, offering that hotline, what's the worst reply you could receive is, well, no, thank you, or I'm fine, or maybe there is no reply, but they end up using it. And so there should never be a concern of, oh, is it the right thing to do to bring that up or to ask that question?
Yeah, there's a lot of stigma around it, obviously, for mental illness and the rest of that. However, so for me, this is just part of my mission now. This is just to make sure that people know about it.
Absolutely. Well, thank you so much, Lucia, today. Obviously, I think we could talk for 3 or 4 more hours, but our listeners might have other things to do.
Yeah, they probably have other things to do.
Do you have any final comments to share with our listeners today?
Thanks very much for listening, and thanks very much for the care that you provide patients. Oncology nursing is amazing, and that you've seen so many advances in cancer care over the last several years, and still it's devastating when your patients die. So thank you.
Thank you so much. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.